and welcome to Pain in the Podcass, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the wonderful Dr. Joshua Craw and Don Wijasoria. And today, we're going to be thinking about interpreting your test results. Welcome in.
Hello and welcome to Pain in the Podcass. Hopefully you're enjoying our content so far, but for all those new to Pain in the Podcast, welcome. Last episode we asked the important question of, do I need a scan? This episode we travel forward into most people's pain journey.
Ooh.
But first, let's learn a bit more about ourselves. Well, we already know these things. You'll be learning about ourselves. Joe, would you like to start us off with your fact?
I would love to. So my fact this week is that I have one leg longer than the other. And so to balance it out, for many years, I used to wear one slipper around the house.
Yeah, I can confirm that during Freshers Week, Joe also continued to wear one slipper around the Hall's residence.
Yeah, and you could hear me. It was like, because obviously like the slipper, I would lift my feet up, but the slipper, like the bottom of it would drag along the floor, like as I was lifting my foot up. So it'd be like, dum, tss, dum, tss, dum, tss, dum, tss. So that was fun.
Yeah,
Wow.
it was like the sound of a zombie crawling through the corridors.
With some espadrilles on.
I don't think Joe ever wore espadrilles, right?
No.
No. Okay. It's okay, Don.
Don?
What's a fact about myself? Have I mentioned this before? Probably not. I like... Okay, this is really strange, but I
Big butts and a can of
okay. Yeah, true. No, I like just really nice mugs and pottery. Yeah.
Okay.
I just really like spending way too much money on artisanal pottery, and talking to the
Pots.
pots. Well, no, more the pot heads, the people making said pots.
Oh, they're called potheads.
Yeah.
Oh, I didn't know that. That's an interesting
Yeah.
fact, actually.
There you go, 2 in 1.
Is this why you tried to steal my coffee mug this morning?
Yeah, you had a really nice looking mug.
Yeah.
I didn't realise that was your morning ritual mug.
Yeah, it's the only one I use in the morning,
Ah,
and I will not use any other
I
mug.
can see why. It's like sparkly and blue and...
He made Don down his coffee so that he could then have the mug back, so he could requisition the mug.
So it's going to be very intimidating when it comes to mugs.
Well, I wouldn't say intimidating. I'd say striking fear in the heart of my foes.
Okay, so worse.
Right, Josh, what's the fact about you then?
So a fact about me is my most treasured possession. It's a close one. It's between a blanket that my mum hand crocheted for me, which is a lovely rainbow assortment of colours,
It is lovely.
It's lovely, yeah.
and a chess set that my late father left me. Yeah, good memories for both.
The chess set is also beautiful, but Josh claims it to be normal size. We claim it to be abnormally large, Don and I. So we're gonna put up a picture of Josh with one of his chess pieces next to his hand, and you can tell us whether you think this is a reasonable size or whether you think it's
With
absolutely
his
massive.
special mug as a reference.
Well,
Or his
okay.
size.
Okay. If we're being honest about chess sets, though, if you look at the World Championship of Chess and all professional chess games, they use a standard size of, I think it's between 3.5 to 4.25
Meters
inches
tall.
for the king, which is a standard size, which is the size I have.
Yeah, I do have to admit, I think Josh might be right on this one, but I'm still excited to see where this goes.
Yeah, I want to know your thoughts at home.
Yeah.
Something I want to know is, Joe, what have you learned about yourself this week?
What have I learned? I have learned that despite the miracle that is microfiber towels, it feels really unpleasant to dry your face with one.
Ooh.
Every other body part, it's honestly like a miracle. You just like touch it to your skin and you're bone dry. But on your face, it's a very odd texture.
Okay.
And so my skin feels funky after doing that this morning.
I was really close to buying one the other day because I do like hiking as well. Oh, second fact.
No more facts for you.
No more facts for me. Yeah. Would you recommend them?
Yeah, 100%.
Just
Well,
not for
I
the
mean,
face.
Environmentally, probably not.
Oh, why?
However, because they're microplastics, aren't they?
Oh, is it?
I believe that's what the microfibers are. They're plastic fibers. But I have never seen something so good at quickly drying you and being so foldable and lightweight. Like if you are camping, there's just no better alternative.
Okay.
But just dry your face with something else. Bring a little hand towel.
Kind of want to. I want to know what it feels like.
You can go try if you want.
Same. I'm gonna wet my face. Oh, you wanted to wash your face, didn't you, Don?
I did this morning, but yeah.
Yeah. So maybe we'll try that. We're not putting that on the Patreon.
The reason he said I wanted to wash my face was because I've got 2 massive spots at the moment. I usually wash my face on a regular basis. It's not like a new occurrence for me. I've not gone for all these years without washing my face.
And I can confirm that these spots are beginning to gain sentience.
They are.
Wow.
They'll develop their own facial expression soon.
Wow, that is so horrible. Don, what have you learned about yourself this week?
I've learned that for those of you listening, you probably can't tell, but I am Asian. Are
you?
Yes. Sorry, Josh. This is a new revelation.
Jesus.
So I'm Sri Lankan, and that means that I grew up with a lot of curry in my diet. Beautiful curry. Really interesting. It's very different to what most people might know from Indian curry. Sri Lankan curry is slightly different, but nonetheless spicy regardless. But I've found out that I don't really handle spice very well anymore.
Yeah, I can confirm. We had a Vietnamese sit-in meal last night, and Don went ham with some chili oil.
See,
but you could deal with it.
the thing is,
in the
I can,
mouth.
orally I can deal with it.
Is it just after?
It's just in the stomach. It's just uncomfortable, and even after the stomach stage, that's fine.
Cause it burns.
No, I don't think
No,
it's ring
no.
of fire. He's saying there's no ring
There's
of fire.
no ring of
and
fire.
No mouth pain. It's the
It's
middle
just
bit.
the stomach. Yeah. Does that mean anything?
I don't know.
Is this like?
It means that you were wise to go and get a McFlurry to try and cool your mouth.
So yeah,
or a milkshake.
I did go to McDonald's and get a mini McFlurry to cool my stomach, which did help a lot. Thank God for the mini McFlurry.
Yeah, so I'm actually going to give some medical advice to Don here. You're going to hear it here first, me actually giving somebody medical advice on Pain in the Podcast. Sounds like you might have gastroesophageal reflux or some gastritis that's kicked off by spicy food. Recommendation, you could potentially see your GP.
Ah, okay.
Or you could have some Rennies for when you have...
I've now become that person that carries Rennies everywhere.
Yeah.
They're in my car, they're in my every single backpack, yeah.
They're in my ears.
There is also a picture of me floating around somewhere on somebody's phone of me in a Nando's sat there with a bottle of Gaviscon next to me.
That's when you know that you've hit that age where things start to decline.
Yeah, I did eventually succumb, go to the doctors and get some omeprazole, but before that...
Beforehand.
Have either of you been to a Nando's recently?
No, last time I went I got food poisoning.
Oh.
Okay, so yeah, I don't typically go to Nando's. It's too cheeky for me. So
Cheeky.
but I did go a couple of weeks ago because there was nothing else open, and I was very disappointed. The sauces aren't spicy anymore.
Are they not?
No.
Even the extra.
The extra
spicy?
hot. The extra hot was just what the hot used to be.
Do you know, even years ago, though, I always feel like the extra hot sauce maybe isn't even as hot as jalapenos,
Really?
in my honest opinion.
Okay, no, I think that's false. I think they are.
Maybe I'm just weird.
Yeah.
Yeah, I am weird.
Josh has got abnormal sensations of Scoville units.
Yeah, exactly. I do need to go to Nando's because I get a discount.
You get a discount.
Got a blue light card.
You could get
Oh.
better discounts, to be honest.
Could. It's £4 maximum.
Well,
that's
it's
shit.
just max of £4 off.
Yeah.
Go to Asda, 10% off whatever you spend.
What?
What?
Yeah.
Are you joking?
You have to buy a voucher via the blue light card.
Oh my god.
Yeah. On Asda Rewards on the app. There you go. Listeners at home, if you work for the NHS, get a blue light card.
Joe has just changed my entire outlook on shopping.
Yeah. There you go.
Oh,
Either
jeez.
way, now that we've had that
Yeah.
that bombshell,
Josh, what have you learned about yourself?
Yeah, I've learned some. Well, it's something that I already knew about myself, but it's definitely been reinforced over the last 48 hours, which is I'm not very good with computers.
this is true. Josh, at every point of the preparation for these last handful of episodes, has just been sat there going, yeah, I had the notes for this, but I think I've deleted them. He'll go over to his computer. He's got two big monitors set up, and he'll go, yeah, it's probably on here. He'll go, it's not on there. So he'll go to his laptop, And go, it's probably on here. And I'm like, oh, well, maybe it's on the Google Drive for the podcast. And he's like, oh, it won't let me log in. And he tries to log in, and there's some weird two-factor authentication site I've never seen before, and I'm pretty sure is a deadly computer virus came up asking him to scan a barcode. So I fear that Josh's laptop won't survive many more recording.
I'm not sure
sessions.
Josh will.
Yeah, genuinely, it's been the most stressful weekend of my life.
Those viruses are going to get to him somehow.
You need to put tape over your camera, I think. If
Yeah.
there's these viruses, I think you've got to...
I mean, I used to, but then it broke off.
You could get more tape. There's not a tape shortage.
I just love how you just gave up.
I was like, do you know what? If somebody desperately wants to see me through a camera, just do it. I don't care. We talked last week about Joe having a stalker. If you really want to stalk me, just go for it.
You're in for a treat.
Famous last words.
So that was the last we ever saw of Josh.
Yeah. Yeah, as we spoke about then in the intro, as Don mentioned, we're going to dive a little bit deeper into the patient journey in this episode. And so we're going to be talking about interpreting test results. So we spoke about the scans, and scans are a big part of the test results you might have if you've got chronic pain. But we want to just kind of dig a little deeper into what the experience is once you've had the scan.
Yeah. Yeah, that's exactly what I wanted to look into. So you've gone to your GP or whichever health professional you're seeing. You've managed to get the scan that you feel like you needed, or the doctor said that you needed to get a diagnosis or to rule out any diagnosis or what the cause is of your pain. And now you're in a limbo, really, aren't you?
Yeah.
Like, it's almost like a Schrodinger's cat, almost, of, oh, I do have, let's say, arthritis, and I don't at the same time.
Well, that's a good analogy.
Schrodinger's arthritis.
Exactly, yeah, it would be a good band name.
Yeah.
That could be the Pain
No one
Podcast
can play a
band.
guitar.
But everyone
they're
can play guitar.
Yeah.
It depends.
Yeah, and I can and can't play the recorder, apparently.
Yeah. I'm leaning towards can't, but...
Yeah, I'm leaning on can't. I can do one round of
Twinkle, twinkle,
Twinkle
little
Twinkle so
stars.
far.
Yeah.
That's after an hour.
Yeah.
I don't feel that's too bad.
That's not bad.
And
yeah.
what's funny is you're listening to this after we've shown you more of the 20-hour challenge. So
Yeah.
you're listening to the past. But there you go. Just a quick point as well. We spoke about do I need a scan, but what we didn't mention in the last episode was how long it takes to get one.
Yeah, and I think that is something that it's a bitter pill to swallow for a lot of people, considering how the NHS works. So do we know how long scans take, roughly?
Well, around... There's usually a 22-day wait for a diagnostic scan.
Oh, is that on average, or is that just the NHS says you have to wait 22 days?
That is on average, I'm afraid.
Okay.
But this massive thing that impacted all of us called COVID.
Ooh, don't use the C word. Ooh.
Sorry, trauma there. That happened a few years ago. So since then, there's been a huge spike, obviously, and people are now often waiting for more than 6 weeks.
Yeah, and I think the 6-week point is an important thing to mention because that is the NHS target. They say that people shouldn't wait more than 6 weeks for a scan. But I think people on this sofa here included, when have I ever... Well, Joe, let's start with you, shall we? How long did it take you to get a scan?
For the scan where the person said that I hadn't torn my tendon and they didn't believe that I had and wouldn't send me, that took me over a year. But we're not going to count that because they disagreed, even though they were wrong, and I did have a tear. So, haha. Really depressing 1-0 to me. But yeah, when I actually was going for a MRI as part of some rheumatological investigations, I had to wait 11 months for a scan on my back. And that was what they said was the absolute fastest. And this was pre-COVID as well.
How long was that?
11 months.
11
this was
months,
pre-COVID.
Jesus.
So, because I got an appointment letter, it was December 2018, and I got a letter saying, your appointment will be in November. And I was like, that's a bit weird. Have they sent this letter late? November 2019.
That's insane.
Crazy. Absolutely crazy. So, yeah, 11 months for me. Have you had any kind of similar wait times, done any?
No, nowhere. Thankfully, nowhere near as near, but it's still, well, quite bad. I think I was waiting for about 2.5 to 3 months.
Yeah, still bad.
Yeah, that's still not great. I think I saw a stat where the target is for only 1% of patients to wait more than 6 weeks.
Okay, that seems like a very reasonable target.
Yeah, but
Yeah.
at the moment it's around 25% of
Wow.
patients who wait more than 6 weeks.
Let's hope you didn't injure yourself during COVID, eh?
Yeah.
I think for me, I'm not lucky, but I had a scan before COVID and after COVID, so I think that people can agree that that's the big distinguisher in terms of waiting lists.
Yeah.
Before, I think I waited, so I had an MRI of my knee. I think it was 5 weeks I waited, so we met
pretty
the
much.
target, so
Yeah.
very happy. But afterwards, I had an MRI of I had an MRI brain actually.
Oh, cool.
Yeah, we don't need to go into why, but I did have an MRI brain, and so it's a more urgent one than for my knee, for example, and that was 2 months, so it was over the 6 weeks, but
Even
still
though it's
pretty
more
quick.
urgent.
Yeah.
Yeah, funnily enough, who knew?
Yeah.
And when often asked why it takes so long, or why certain scans take longer than others for certain people, it's usually because it depends on the urgency and severity.
Yeah, I think you
that's
was
kind
talking
of-
to a radiologist, wasn't you?
I was,
about
yeah.
that,
So yeah, that's what she said. That it just depends on how urgent it is, the patient's circumstances, and I just think it's very unclear how they decide who's prioritized over other people.
Yeah, so I think I can spread a bit of light on this. Okay.
Do
So
you mean shed light?
no, I want to
Spread.
spread some light. I've got my knife here. Let's butter it on. I mean, you've been practicing with your paints. Have you got a palette knife?
I have. We can
Okay,
we
let's
can
spread
some
some
light
light.
with the palette knives.
Yeah. So I think the majority of people know about a 2-week wait rule. Do you guys know about that?
No.
No.
Oh, you don't? Oh, maybe it's just me being a doctor assuming people know. But the 2-week wait rule is for cancer. So if somebody suspects you have cancer in terms of your medical professionals or your doctor, GP, they refer you on a 2-week wait rule, which means you're going to get seen by a specialist within 2 weeks. And
Okay.
your scans are going to get expedited.
Yeah.
So you might have a staging CT, you may have an MRI of the brain if they're thinking it's something intracranial, so within the brain. But in an ideal world, that would be every scan. But the fact is, the NHS is a very stretched resource, and scans are a resource, despite what you might think.
Yeah.
So if you're a young person who's been having back pain for 6 months, well, you've managed 6 months with this back pain. Is it really going to matter too much if you wait 6 months more?
Yeah. Never what you want to hear, but
It's not. No.
good point.
But that's the thing. NHS wait times don't take into account, okay, yeah, I've managed 6 months with this back pain. It's affecting me every day. I've managed to come to the GP. I've managed to get my scan. An appointment for my scan, in fact. But yeah, those next 6 weeks might be hell. You might have a flare. You might be worsening.
Yeah.
Doesn't take into account that.
And it's tough, I think, because there's actually a lot of misuse of scans. So that comes from two places really. It comes from, for some clinicians, it's a lack of education about when and when not to use diagnostic tools.
Yep.
So, for example, the symptoms that I present with in terms of my back pain, none of that merits a scan. But I've had more scans than you've had hot dinners, partially because clinicians didn't understand when to use them, and secondly because there were difficult patients like me who were pushing, and sometimes it's just easier to say, okay, fine, you can have a scan. The doctors know it's not going to show anything. Like, I've got a few stats here to kind of emphasise that. There was a study in the US of 68,000 people with lumbar spine pain, so like lower back pain, who didn't have any red flag symptoms.
Okay.
So this was like a retrospective study, and they looked at all these people who were scanned outside of recommendations. So there was nothing that meant they should have been scanned, but they were scanned anyway for whatever reason. Mm-hmm. And out of them, 1 in 2,500 had a serious pathology. So across that whole group, that's like 28 people out of 68,000.
Yeah.
Which really, that's worse than your odds of probably just picking people off the street and scanning them.
Yeah.
Like the likelihood of you having something really pathologically wrong if you don't have a red flag symptom is basically zilch. And that's not to say like it's not great that they caught those 28 cases and could maybe help treat them, but actually it's really poor use of resources. And as well, like there was an education program in Australia where they taught clinicians how to actually refer properly for CT scans. Like, here is a almost like algorithm, like, do they have this? If so, yes, refer. If not, then no, don't. And they managed to cut their scans by 11%, and save 12 million Australian dollars in just 1 year.
That is very impressive.
Yeah.
And just think of all those people that need scan. Well, how the effect it'll have on the waiting list for the patients within that population.
Oh,
as well.
enormous. And also the cancer risk as well, because like in this study, they quoted that people in Australia who have undergone a CT scan over the course of their lifetime have a 24% increased risk of cancer.
Yeah, I mean, yeah, and it's cumulative. So when we talked a bit about radiation last episode, but there is a risk of developing cancer, and the younger you are, the higher the risk because you've been exposed at a younger age, so you've got more chance of developing cancer. This is why, in terms of CT scans, we've got a lot lower threshold for older people in terms of radiation risk. But one of the things that I sort of see as well within my practice is that it depends what the patient says.
Yeah.
It really does depend on what you say, and that's why you need to advocate for yourself. It's about knowing your symptoms, but more importantly, it's not just the symptoms, it's how they affect your life. So if you go to your GP, I've got this terrible back pain, do you know what? It's just not. It's all right most of the time, but sometimes it just doesn't help, and I have to take a day off work. It's probably not going to get your GP excited in terms of investigating more.
Yeah.
If you go in there and you tell them how it's affecting you when it is bad, so do you know what? It's so bad I can't even manage to cook for myself. It's really impacting me. You know, it's making me feel down. I'm not being able to get out and be as active as I used to be. That's really going to improve your chances of getting the scan. Now, I'm not here to try and coach you through how to get scans on the NHS. That's not what we're doing here. We're talking about making sure that you can advocate for yourself. So, looking into, for example, we use back pain as an example all the time, but
classic.
Looking into it and really taking a note of your symptoms, like even doing a symptom log, because we all know that it's very easy to forget symptoms.
Yeah, definitely.
We mentioned that on our benefits, brief foray into benefits, being that, you know, when I go into a doctor, I forget half of what I want to see.
Yeah,
Mine is
that's if
super
it's on a good
clouded.
day.
Yeah.
I think we've read an article on The Guardian, which I think is somewhat reliable news source, in terms of waiting times for the scans. And, well, Don, do you want to break us in on the bad news?
Oh, there's a lot of bad news. So the longest waiting time found for, I think, particular NHS trusts were at the Sandwell and West Birmingham trusts, where someone waited 914 days. 914 days.
It's almost 3 years.
That is crazy. For an MRI scan.
Wow.
665 days for a non-urgent X-ray, which, I mean, I get it's non-urgent, but that's still ridiculous.
Yeah.
693 days for an ultrasound and 367 days for a CT scan.
Wow.
Usually people with heart problems are the ones most affected by these wait times. So examples from the NHS trusts include a 49-week wait for the echocardiogram and a 475-day wait for an angiography.
Angiography, yeah. So that's a scan that looks at the vessels around the heart. Yeah. So, for example, if you was investigating for angina.
So, yeah, I think that leads to my question of who or what determines the priority of these scans? And, well, another random question. Why are people with heart problems more affected?
I think that is a very good question, Don. And it's going back to what we mentioned. It's all about how severe or how urgent the scan is. So if you go in with symptoms of a stroke, you're going to get a scan within 8 hours. That's just going to happen. If you go in after having a traffic accident and you've smashed your leg to pieces, you're obviously going to get a scan. If you're a young person who is now in so much pain that you're not able to walk, for example, I think we can agree that you'd probably get a scan quicker.
Yeah.
The problem lies in, particularly with pain, is when It's not so severe that you'd be considered as disabled, but you're managing. And that's the issue. It's people that are managing that are the worst impacted when it comes to these wait times.
So people who kind of get this pain on a gradual rate, where it becomes quite intense, but because it's been happening over a long time, are they less likely to be seen?
Yeah, absolutely.
To be scanned, okay.
Yeah. And you got to think, you've got all these people with cancer who I think everybody will agree need to get scans.
Yeah. I think it's a good example that people use is like when you've got a team at work, you've got, say, 20 staff, and 5 of them get let off. The worst thing that the 15 of you can do is perform at the same level you were before. Like everyone, in inverted commas, pulling up their bootstraps and just getting on with it. That's actually really bad because then it convinces the bosses that you can work with that many people.
Yeah.
And it's this kind of thing again, is just like, just because you're coping, it's like that convinces the healthcare system that, yeah, you know what, you're coping. You might not be coping well, but you're coping well enough that we don't need to prioritise you.
Yeah. Even though you might be treading water.
Yeah.
Yeah.
Yeah, absolutely.
And I think we've seen this in successive years. Let's pick a random number out of the air. Over the last, say, 14 years.
Yeah.
Yeah. This was recorded in 2024 for anybody that's listening. I think that we've seen a lot of cuts to services, and with those cuts, we've seen less ability to meet demand.
Yeah.
Not just that, we've got an ageing population as well. So with an older population, we've got more people that need scans for cancer, for strokes, for accidents at home, in fact. And that's all putting a burden on the system.
Yeah. And in case you're sitting at home maybe and you're thinking about, you want a scan about your pain, it's really important that you maybe speak to your GP first about some of the symptoms that you're having, because getting unnecessarily scanned, so you might think of this as being harmless, like I'll go for a scan, turns out there's nothing, we're back in the same position. But actually, I've got 3 really interesting studies.
I'd love to hear about them.
Let's hear these.
So one of them said that in people who had their lower back unnecessarily scanned, they were 68% slower to come off disability benefits. So if they were like temporarily disabled by their back pain, it took them 68% longer time to get back to work, and they cost more than $13,000 additional costs per year in healthcare.
Wow.
So that's just from having the scan. So say, for example, what we said earlier on, that there's these maybe unrelated wear and tear changes that occur over time. People become convinced that that's the source of their pain, and because they're convinced that's the source of their pain, they then go looking for treatments to address that maybe aren't actually relevant to their health.
Yeah, and I think that raises another good point in terms of, you mentioned that 68,000 people that have been scanned without any red flags.
Yeah.
When you scan somebody, you're going to find something that looks a bit weird.
Yeah.
That needs further investigation.
Oh, yeah.
With
Everyone's funky as hell.
Yeah, like, you got to think there's over 7 billion people on the earth. There's a lot of variation of normal. And some of those variations of normal don't look quite right. So
Mutants.
You might... Well, no, not quite mutants. Well, maybe if you eat a lot of bananas or have too many scans.
Or have too many transatlantic flights.
Yeah, indeed.
But if you live in a city with a nuclear plant, you're fine.
Yeah.
Supposedly, you're almost safer.
Yeah.
Yeah, who knew?
Bananas.
Clean energy. Just avoid those bananas. That's the best medical advice.
Yeah. But just as well, there's other 2 studies I was speaking about. Interestingly, people who get these inappropriate MRIs, so the unnecessary MRIs, have a 11 times higher rate of back surgery. So they're, again, identifying things that probably aren't the cause, but people will see something on a scan and therefore they want to deal with it, even if it's unrelated. So 11 times more likely to go into surgery. They also end up having a higher average pain score than people who don't get scanned. And also, in terms of sort of costs, again, to the healthcare system, the physiotherapy costs are 17% higher for people who have unnecessary scans, and the medication costs are 34% higher. So when we think about maybe how we can deal with this crisis that Don will speak about in terms of scanning and what resources we would need to deal with that, that needs money. And when there's this sort of unnecessary spending going on at the minute for people who are getting scans where they don't need them and subsequently taking up treatment that probably isn't the best course of action to help them manage their pain. And this isn't pinning this on people. I've been in that position. I have been the person unnecessarily demanding a scan, when if I'd looked into it, there would have been no reason. And I'm part of the problem. I can completely accept that. But coming out the other side of it, I see, and particularly now moving into working in the healthcare system, I see that patients educating themselves and working out whether they actually really need a scan, even if that's in combination with their GP in a discussion, that is so valuable. And that will actually help them down the line as well when they need other medical care, because there'll be more money in the healthcare system, there'll be lower wait times, and so you're almost paying yourself back in the future by not using resources where inappropriate.
Wow. Yeah.
Yeah.
Yeah. Absolutely. I couldn't agree with that more, Joe.
Yeah, so Joe, just like you mentioned it, to clear a 6-week wait backlog in 1 month, the NHS would have to hire 386 additional radiologists overnight. That's equivalent to 10% of the current workforce.
That's a lot of people.
Yeah. Wow. Yeah. And as somebody who's applying for specialties training currently, I can assure you that that's not as many people as
Yeah.
are getting trained each year when you take into account people who are retiring.
Yeah. Because you get, I've just had a quick Google now. Recently, the numbers have gone up to 4,100 radiologists in the UK. But you're going to have to recruit staff from abroad because we're not training enough to make up with this.
Yeah.
And since Brexit's absolutely kiboshed people's opportunities to work in the healthcare system here, that's made it even more difficult, because there's a problem that there's a hypothetical solve here in this hiring of more staff, and that's to clear it within 1 month. So that's a short-term goal. But say you wanted to clear that backlog in a year, and so you want to hire 40 new radiographers, we've made it even harder for ourselves to fix that problem by preventing people from working here. So
Yeah, and it's not just that; it's the time as well. Like like an MRI of the spine takes a good chunk of time. You don't just need radiologists; you need radiographers, you need nurses. It's a whole chasm of expenditure and time that's required. Not to mention, if we hired those radiologists overnight, how much is that going to cost as well?
Yeah.
yeah,
Like,
the recruitment costs are huge. I've got a friend who works in the Home Office, and I'm assuming governmental stuff is similar. And he just says that like money that they spend on advertising and recruitment and interviewing is just like thousands and thousands and thousands per job.
and that's going to build up over when you've got the
God,
entire NHS, which is
God,
one of the biggest employers in the entire world.
Yeah. So you've had your scan. You've waited months to finally get it, and now you're left waiting further to receive the results.
Yeah, and these wait times can be agonising, pun intended. It's a time when you're left in, like Josh says, this kind of Schrodinger's cat state where you're, like, I know that when I was waiting to hear back about the cardiac MRI to see if I had Marfan's, it was like, well, there's so many signs that are like, yeah, you obviously do, but so many things that I don't, and it didn't end up having it in the end, but like I was in that state where I was like, if this is a yes, it's going to change my life so much. Like, I'm going to need to be on medications, I'm going to need to think about how I act and my lifestyle factors in a very different way. So it's a really tough position for people to be in this waiting.
Yeah, definitely.
Yeah, so, like, we've already mentioned how long it took us to get our scans, and back then my results came back pretty quick, if I'm being honest.
Yeah. Lucky you.
Yeah, lucky me. I mean, but how do we actually receive those results? That's the question.
It's pretty old-fashioned at the moment in the UK.
Yeah.
I'd say so.
It's letters, isn't it, usually?
Yep, a snail mail, fantastic. And when you open this letter and it tells you the results, it's not necessarily the best written letter.
No.
It's not necessarily speaking in plain English that's easy for anybody to understand. Even myself as a doctor sometimes, some of the phraseology that radiologists use, for example, can be quite ambiguous or can be quite complex in a way that unless you're a specialist in a specific area, you might not actually fully appreciate what's being said. And what I've got here is, it's not a game, it's a bit of a feature.
Okay.
What I'm going to do is I've found some anonymised patient letters. So these are real patient letters. However, all patient identifiers have been removed. So
These are publicly available online. These are not Josh's patients. He
Yep.
has not done anything to produce this data. These are publicly available patient letters, just to emphasise that.
Yep, a simple Google search found these, and I just scanned through them just to make sure that they did follow and look legitimate.
Quick question.
Yeah.
Are these letters written by hand or typed? Hopefully not written by hand.
If they was written by hand, I think we'd see the backlog even worse than it is now.
Yeah.
They can either be computer generated. It could be a case of a copy and paste job from the radiologist report. It could be a doctor that's seen the report and then writes a letter. More often than not, it's a secretary that might type up this for a consultant, for example.
Because otherwise you'd be there like, is the doctor saying I went to Canada or that I had chlamydia?
Indeed.
I just went in because my elbow hurts.
Well, actually, interestingly enough...
No, there's no way chlamydia and elbows are related in that way.
Oh, sonny boy.
Okay, let's hear this.
Let me talk to you about reactive arthritis.
Okay, yeah.
So, infections from STDs, for example, gonorrhea and...
Here I go again.
Mama.
How could I resist you?
Gonorrhea.
Oh, no.
Bacterial infections from sexually transmitted diseases can actually cause an acute arthritic response.
Oh?
So, if you're a young person who was... I'll give an anecdote of a patient I had. Obviously, no patient identifiers. A young chap in his 30s. He'd have been away on a lads holiday, and he'd come back, and now his knee was swollen, painful, and he didn't have any other symptoms other than a painful swollen knee.
So he hadn't fallen over or anything?
No trauma whatsoever.
Okay.
And there's nothing that was to indicate that. And just the way the patient was coming across, I asked him about his sexual history, so unprotected sex and what have you, and he says, yeah, lots actually. I've just been on a lads cruise, and it was pretty eventful. So yeah.
Lots.
So with a hot swollen joint, as a doctor, you've got to rule out septic arthritis, which might need a needle aspirate of that joint. This wasn't hot, and his inflammatory markers, which we look at in blood, they looked pretty much okay. So I think this was a case of reactive arthritis. So his crotch rot had resulted into some pain.
Gosh. What did you tell him?
I told him he needs to go to the clap clinic.
Ah, nice.
Or gum clinic if you're in the UK.
Okay.
Yeah.
Should we get on with these patient record games?
Yeah.
What's the feature?
Okay, so I'm going to read through the letter that the patient got, and I want you to tell me if you can figure out if this is a good letter or a bad letter.
Okay.
So it's a bit like a good news or bad doctor.
Okay. All right.
Are there points in this? If we guess
Has to
different
be.
things, can we get points? I need to regain my my points tally. I'm not on many points in the...
You did win the last game though, didn't you?
No, I did.
Don won it.
Yeah, sorry, it's been a while since we recorded that one.
Trauma.
Don did get a sudden death victory against Joe in our last...
In his banana guessing skills.
Yeah, who knew? Don.
So yeah, is there an opportunity for me to gain back a point this week?
I'll tell you
this
what.
episode.
We'll do it as a sort of who do I think's done better.
Okay.
Is that okay?
Yeah.
Okay, here we go. We're going to be talking about some results that have come back. These might not necessarily all be from scans, just to pre-warn you, but I want you to let me know if these are good or bad.
Okay.
Shall we begin?
Yes, please.
Just do it and do it and do it. No, I can't sing that.
Okay, here we go. Summary. PT3 PN0. Sigmoid cancer with 50 sessile separate polyps, 4 tubular adenomas and 1 serrated adenoma. His CT has shown a suspicious new lesion in segments 8 of the liver. This was hypo-enhancing on contrast. He subsequently had an urgent Primavist contrast MRI and PET scan. Both the MRI scan and the PET show the segment 8 of the liver to be completely normal.
Are you done?
There is something else, but we don't need to talk about that.
Okay.
So, what do you reckon?
I'll be honest. I think I got about 10% of those words.
Okay.
Yeah, I think I knew way less words than there
Good or
actually
bad?
were. Good. Oh, bad.
So we're assuming that the patient is known to have cancer.
Okay, so that's
And they've
never
had another
good
scan.
news.
But how is it in terms of the progression? Is it good or bad?
I think that's what we're trying to just
That's
figure
what I'm
out.
asking you.
Oh, right. I think it's not great news.
Okay.
I think that having 50 lesions already, if I heard that correctly.
50 sessile serrated polyps.
Okay, so having 50 polyps, although they're not likely cancerous, is still really not good wherever it is in your body. But it's good news, I suspect, because they thought there was a tumour, but there turned out not to be in the 8th segment of the liver. But bear in mind, I worked in cancer research, and that, for me, was still 70% gobbledygook.
Yeah. So actually, for me, in somebody who's got a known cancer and we found a new suspicious lesion, it says that it looks completely normal. So actually, this is good. But
What?
yeah.
Yes, get in.
Okay.
But
One point
can
for
you,
me.
Can you?
If I was to read that, the sheer panic that I would be in,
Oh, yeah.
Yeah. I mean,
I'd be distraught.
if you're there with cancer and you said, "Oh my God, there's a new suspicious lesion,"
Yeah.
like you're thinking, "Oh my God, it's spread."
Yeah.
Like this is a report sent to a patient.
Firstly, I'd open up some form of Google Translate because I don't think I understood
No.
any of those words.
And that's exactly what people do.
Yeah.
You Google a word you don't understand, and then you see some absolutely terrifying results.
You can see worst case scenario a lot of the time.
Yeah, which is why Dr. Google is not a good example. In fact, I'd say if you're a patient and you've received a letter like this, Googling some of the terms that you don't know might be not the best for your mental health.
Go discuss them in person with your GP if you can.
Yeah.
But then,
yeah.
how long should you wait for that?
Depends if you can wake up at 8 in the morning and get front of the queue in the phone line, doesn't it, really?
Yeah.
Most of the time.
Yeah, so if you work a 9 to 5, you'll never see GP.
You're buggered, yeah.
I mean, I struggle in the job that I do getting GP appointments.
Yep. You're literally a doctor. The irony.
Yeah, the irony of it, yeah.
I mean, I was unemployed for a bit and just in between jobs, and I still struggled to get in the queue for a GP appointment.
Which is just wild.
'Cause
And
why-
that's like, there's no other priorities at that point.
Why can I not just schedule one for 2 days from now? Why does it have to just be on that day? And even if it is just on that day, it's either in the morning or in the afternoon. And I have to
But
call
you have to
again in the
call-
afternoon
yeah.
for an afternoon appointment.
Well, this is the whole thing about 24/7 NHS, isn't it? Like, the majority of adults are working. So 9 to 5 really isn't an appropriate time, but that's when all the appointments are.
Yeah.
How are you supposed to be able to do that? You're going to have to miss work.
Yeah.
And we've talked about how the effects on missing work.
Yeah.
Can look.
Yeah,
How your colleagues perceive you.
Optics. Yeah.
exactly. How your employer perceives you.
Yeah.
All possible negatives. So yeah, the thing to break down in this is showed that it had a CT with a suspicious lesion in the segment A of the liver. Then it goes hypo-enhancing on contrast. So hypo-enhancing doesn't mean that it's a solid tumour. So it'd be hyper-dense if it was a tumour. That's from my knowledge. I could be wrong. If you're a radiologist listening, please feel free to berate me about my lack of understanding. But the way I've read this is that both the MRI scan and the PET shows that the segment A, which they thought was suspicious, was completely normal.
Okay.
But even with it saying that, it's still ambiguity there, isn't there?
Yep.
Yeah.
Okay.
1-0.
1-0 to Joe.
1-0 to the champions.
To the one who's done a PhD in cancer research. Great start for me.
Feels somewhat unfair, doesn't it?
All right, on to the next, Josh.
Okay. So this isn't necessarily a scan result, but it's more about the format of a letter.
Sure.
RE, and I'm going to use a fictional name here. Mr. Smith, born on date of birth. Diagnoses: erythrodermic psoriasis. 2. Hypertension. 3. Polycythemia. 4. Non-alcoholic steatohepatitis. 5. Obesity. I reviewed Andrew again in clinic today. His psoriasis has now flared and has become erythrodermic within a few weeks of stopping Sorolin plus ultraviolet A. His psoriasis area and severity index is now 45 out of 72, and his dermatological life quality index is 16 out of 30. Systemic treatments are now very limited to the grounds of his comorbidities. A biological agent is now our preferred option.
Okay.
So let's say that you went, for example, you went with psoriatic arthritis and you've seen your dermatologist. This is what's being suggested.
Shall I mean to go first again?
Oh, let's go with Joe first.
I think it's bad.
Okay.
I'll elaborate more why in a minute.
I also think it's bad news.
How bad? Out of 10 on a level of
I
0
would
to
say
really
it's
bad.
about 5 out of 10 bad. As in, it's still bad. But
Okay.
6 out of 10.
I'm going to go 5 out of 10 bad.
Okay. Why? What is it, the things there that are making you worried?
It seems like the treatment that they were on before isn't working anymore, and they're having to kind of ramp up. So there's a lot of other conditions going on at the same time. But to be honest with you, like all the outcome measures they spoke about, all the scores and stuff, I've got no idea about. So I actually don't know whether they might be good scores for all I know.
Yeah, that's what was throwing me off. The scores seemed like there was a bit of leeway there,
Yeah.
but the overall kind of summary didn't.
Sounded bad.
Yeah.
And do you know what? I'm not a dermatologist.
Are you not?
I'm not a dermatologist.
Okay.
But so the quality index. So how's their quality of life?
Yeah.
And it's sort of middling, isn't it? But yeah, I'd say this is showing that this person's psoriasis, or even if they came in with psoriatic arthritis, is getting worse.
Okay.
Okay.
Yeah, but
On a level of 0 to 10 bad.
I don't know. Is the answer?
Damn it.
Without seeing the actual patient,
Right,
it's
still
difficult to
1-0
say.
then.
And with those index scores, you'd have to see comparative to what.
Yeah.
So what is that patient?
How were they before? What's their baseline, etc.
Yeah, but yeah, you're right. So it's saying that now systemic treatments, so like taking steroids, aren't working.
Yeah.
And a biological agent, which I know Joe knows about, but this is sort of like antibodies, like your body makes. But in modern medicine, we've sort of harvested this to target specific sites, so they can so they can act as treatments. You don't need to go into great depth of detail about that, but it definitely is an escalation in treatment that's required.
100%.
And that's not really highlighted that much. So a biologic agent is now a preferred option.
But the patient has no idea what that is.
Doesn't know what that is. Plus, those biologic agents have side effects, like all medications that work.
Yeah, and the biologic side effects, I know a couple of people who've been on them, and they can be rough. Some people don't seem to have many side effects, some people it really goes to town on.
Okay, I'll tell you what, we'll go for one more, shall we?
Yep.
Decider.
So is it?
It's not even a decider.
It's not.
It's if Don can...
Okay, if Don gets it back, then we'll do another one as a sudden death.
I think we're going to have to get another one, because
Okay.
this one is... Okay, here we go. Your CT scan is back on my desk, and the swelling of your kidney is entirely resolved. I am totally at a loss to explain how convincingly you demonstrated pelvic ureteric junction obstruction on your initial investigations, and then so convincingly failed to do so in the theatre when we looked and indeed on the subsequent CT scan. I am, however, jolly pleased for you, as it saved you having to have an operation. I have discharged you as of today, and hope you have a lovely summer.
Was the doctor calling the patient out?
No.
But-
Well, who knows, maybe.
I think it sounded like a compliment.
Yeah. Did you?
Yeah, it was
Oh.
just like it's amazing how you managed to be so this in this and so this in this, and you're like, well, thank you, doctor.
Okay.
I
Okay.
appreciate.
Okay.
So what do you guys think? Good or
It's
bad?
very good.
I think it's very good.
I think it couldn't have been written better as well, in my opinion. Like, it's just so clear. Like, you don't go out of that letter thinking, God, there's so much uncertainty. Like, you know what's going on.
It's quite humorous.
Yeah.
I love this letter.
Yeah.
I'll be honest, when I found this, I was like, oh my God, I wish all letters looked like this.
Yeah, I'm going to have to start writing letters like this when I qualify.
Would you be concerned though?
No.
I just think, wait, I don't know. I feel like I'm just conditioned to expect very sophisticated and difficult language in these letters.
Yeah,
So
maybe.
seeing an absence of them is quite concerning sometimes.
Hot take.
Yeah.
Yeah. Yeah. Well, from this, it looks like the patient came in with a kidney stone
Yeah.
that was very barn door, so just absolutely clear. All the investigations indicated that, and then on subsequent scans,
Didn't have one.
didn't have one.
Wow.
Yeah, I mean,
Good stuff.
Yeah, it's past it, which is unusual for the location where it was.
Wow.
No, I did get a slight impression of the doctor was just disappointed that there wasn't one. It was like, how dare you?
No, I love a good kidney
Yeah,
stone.
yeah.
Oh, I got my good scalpel ready.
Wow. So was that a draw on that question as well?
It was.
Does that mean it's a 1-0 victory to me?
That means that Joe wins.
Okay.
Woo! I finally get to rack up a point on the leaderboard.
Completely unfair,
Congratulations.
but well done, Joe.
You've got more than enough, it's fine.
What?
Yeah.
You had such an advantage in that.
But you've got points already. I've got no points.
It's funny how that's worked out.
Yeah.
That's
But
nice.
we spoke a lot about scans, and there we just sort of started to breach on other tests that might be seen. But the other key one you're going to have in chronic pain, and that I'm sure we've all had bucket loads of in the past, is blood tests. And
Yeah.
now I don't know about you, Don, but
You know what? I've never done a blood test.
have you not?
Never done a blood test.
Do you know how they work? Because I'm not really. I don't really.
I don't
know
think.
what we're
I don't
looking
even know
for.
what my blood type is.
Oh, I don't either.
Okay.
You never told me.
I'm A positive.
Oh, you're very positive.
Second most common blood type.
Sounds
I've
like
always
you're
thought
bragging
you were
about that, to be honest.
Hmm?
Sounds like you're bragging about that.
Actually, it's not a brag, actually. It's a really good blood type to have because it means that
You can donate blood to more people.
donate blood to more people and
Definitely.
there's more
bragging.
people that donate that have A positive. So, like, you don't want a rare blood type. So, I've seen some people that are bragging, oh, I'm AB negative. I mean, that's great, but when you need an operation and there's no AB negative,
Yeah.
How?
you'd use O negative. Just saying.
Oh, negative. Okay. How far do these blood banks go when it comes to sourcing?
Every hospital has an adequate quantity, but it is a limited quantity. So it's
But do they I think Don's asking, like, would they transfer?
yeah, they'd blue light it in an ambulance,
Okay.
or if it's so urgent, you could even consider
What
helicopter.
about in really
Shit.
rural areas like, I don't know, the Scottish, what is it, the islands?
Hebrides.
Yeah, that's the one. Yes.
Yeah. So you would either, well, if you're at the point where you desperately need blood, you'd consider either transporting the patient or transporting blood to the patient. So if in that sort of incredibly rural environment, you may even consider helicoptering
Yeah. Okay.
blood products. But we do have, you might have seen them, like blood carrying cars.
Yes.
Oh
yes.
yeah,
that
no, I have seen.
transport blood.
And motorbikes, well, blood bikes.
Exactly.
As well, yeah.
Yeah. But I mean, in most major hospitals, you're not going to have an issue no matter what blood type you've got. It's just in case, let's say, for example, you got two people with a rare blood type in a hospital, and one of them's had a major hemorrhage, so they've used up loads of the O negative and the source blood.
Yeah.
Yeah, which is why O negative is so good. We've gone on a real tangent today.
Yeah.
Yeah. I wonder if blood types have been used as horoscopes as well.
They have, yeah, particularly in Asian cultures.
Oh,
I think it
okay.
might be Japan. I could be wrong, but they sort of believe that different blood types have different personalities.
Wow.
So
Either way, can you tell me how blood tests work?
Yeah, so in terms of chronic pain and blood tests, there are a few things that we do want to look at. So the main thing in terms of pain is inflammatory markers. And there are a couple of inflammatory markers that all doctors know about and what we use. For example, erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. These are two proteins that increase when you have inflammation in your body. Now, they're not specific in terms of what's causing it. So we use CRP, for example, for infections. So if you've got a pneumonia, your CRP is going to shoot up. If you've got arthritis, your inflammatory markers are also going to increase. So the important thing about inflammatory markers is knowing what your baseline is if you've got chronic pain. So if you've got arthritis, you might check an ESR rather because it's a more long-term marker. You can see that from your baseline, if you've got an increase, that you're having a flare, for example. Or ESR specifically can be used for polymyalgia rheumatica, which is a condition that we will be coming across at some point. And the other main things are for diagnostic purposes, and these are sort of immunological blood tests. So things like rheumatoid factor,
Yeah.
yeah, and a host of other immunological results, which we won't get into too much today, because I feel like when we talk about specific conditions, we can talk
Go
about
into them
those
more, yeah.
in depth. Otherwise, this would just be a lecture on immunology. But the main thing to look at when you get the results for those is, one would hope that it's a bit more like the last letter that we looked at,
Yeah.
where
Clearer.
it's a doctor that's interpreted the results and told you about them. So it's not just a list of numbers where it's like, the CRP was 300, or the CRP was less than 4. I mean, if you don't know about CRP, what does that matter?
It could be 1 billion, I wouldn't know.
Exactly. I mean, if it was 1 billion, I'd be incredibly worried.
Okay.
If it was 300, I'd be thinking you're on death's door.
Oh, wow.
Yeah. So,
Okay, speaking of explaining the results in a coherent manner, could you translate into layman's terms immunological factors? What on earth does that mean?
Proteins in your blood that get released when you have a reaction to something. Whether that's an
Okay.
infection or arthritis or ankylosing spondylitis or rheumatoid arthritis, like all these things. It's- Yeah.
So exactly
body's
what you just
reaction.
said.
yeah.
Yeah.
In
Alright.
essence, yeah.
Cool.
So Joe actually knows about some other genetic factors that we can test for as well. Is that right?
Yeah. Like I said earlier on, my grandfather was diagnosed with ankylosing spondylitis, and there's a gene called HLA-B27, and so you can do a blood test to check if you are positive for that gene. If you have it, it doesn't guarantee you're going to get ankylosing spondylitis, but you can't have ankylosing spondylitis without having that gene. So it's basically like, it's not a rule in, but it's great as a rule out. So I do
Yes.
have the B27 gene, just like my grandpa did, but no signs yet, other than back pain. But I don't know, my flexibility's still good. I've never had any signs of it on a scan, so it's unlikely that I've got ankylosing spondylitis.
Your flexibility is surprisingly good for someone of your height.
Yeah.
I mean, you can't. Can you reach your toes?
I can reach my toes.
Yeah.
My hamstrings are tight as hell at the minute, but yeah, I can
I remember
just about do it.
doing yoga with you once. Very surprised.
Yeah.
It wasn't an actual yoga session. We were just
Dicking around.
dicking around in the kitchen. All three of us. Yeah.
That was nice.
Yeah. And it's important to know that HLA-B27 isn't just specific for ankylosing spondylitis.
Oh, yeah.
It covers a whole host of conditions, not necessarily just pain related either.
Yeah. I want to make a brief note before we finish up about this kind of interpreting your results and maybe getting a diagnosis. I know that for a lot of people on their journey, it's very important for them to receive a diagnosis. It gives a reason that they can explain to people about why they hurt. It gives them this kind of almost excuse for why their quality of life has changed. And we've said a lot today about unnecessary use of healthcare resources and pushing for the wrong thing and whatever, but by no means do we want to kind of berate people in pain. Like, we've all been in that position, searching for a diagnosis, and the vast majority of people with pain feel this is a kind of a really important part of them taking control of their pain and getting on with their life. So please don't ever think that we're sort of saying that people shouldn't be doing what they're doing. We understand that everyone's at a different point on their journey. A lot of people just want to know what's going on with their body, and we can't criticise that at all, but we just want to give you the best quality information that we can give here so you can make your own informed decisions.
Yeah, and it is about patient independence. Like, you've got to do what you've got to do.
Exactly.
Definitely. Joe, I think there's a very, very important question that we've not quite answered yet.
What would the Egyptians do?
What would the ancient Egyptians do? Ancient Egyptian laxative of the week.
Okay. Our ancient Egyptian laxative this week is, drumroll please.
I can't.
This week, it's caraway seeds.
I've heard of this one.
Oh, have you?
Have you
Yes.
Have you tried it?
No, I've not tried it, Josh. But caraway seeds is just one of those kind of mysterious ingredients that is used a lot in Asia for multiple different things.
Including laxatives. Have you heard of it being used for that before?
I think I have, yeah. I can't quite remember where specifically. Yeah. I didn't know it was the ancient Egyptians as well.
Let's have a look and see if there's... I'm going to quickly
Don't
type
think-
in caraway enema and see what comes up. Peppermint oil seems to be good for non-ulcer dyspepsia.
I've prescribed peppermint oil.
In India, for parasites, you can do an enema made up of caraway oil.
I thought it might be India. Yeah.
Cool. Wow. Okay. Well,
Mm.
that,
Maybe
I
the
didn't know
Egyptians
I'd know
were on-
that.
Maybe the
Yeah.
ancient Egyptians were on something.
yeah.
Clearly, they were onto a lot of things, as we've seen in these episodes.
We were sat on a lot of things.
We all love a bit of Octo.
We do love some Octo.
All right. So, I think that brings us to a close on this episode.
Yeah, I think
Yeah.
you're right.
If you've, as always, if you found any of the information that we told you about useful, please let us know. If you've got any recommendations on what kind of silly games we should play, let us know.
We'd
love to
love
hear
your recommendations.
Yeah, always, we welcome your questions. If you'd like for us to talk about a certain topic, do let us know. Anything that you're kind of got questions about, and I feel like we all have a lot of questions when it comes to chronic pain.
Yeah.
So yeah, definitely send us to those our way
How can they send them to us?
on our email, which is
paininthepodcass@gmail.com. How else can they contact us?
via our Patreon.
I wasn't thinking that.
That's because it's not a means of communication.
How else can they contact us?
I've got one. Alternatively, you could send a carrier pigeon specifically to Don.
Please don't.
Or
I-
via our social media.
I will shoot said pigeon with whatever missiles I can find.
Oh my god, what?
Yes, anything, oh my gosh, what's the word to describe throwing objects? Projectiles.
Yeah, I mean,
Yeah, I'll throw all of them.
okay.
Just because, okay, if you don't know, I have a crippling fear of birds.
And you
So-
should have listened to episode 5.
Yes.
Either way,
Stop it, Josh.
you can reach us on our email, on our social media, or by carrier pigeon. And you can see loads more behind the scenes footage and exciting things on our Patreon. Is there anything else you can find on our Patreon?
Yes, a lot of bloopers.
A lot of bloopers.
A lot of bloopers. You can also find our progress on our Etsy empire.
I'm not sure I'd call it an empire.
I'd say we're fridge magnates.
Hey.
And please don't tell Inland Revenue.
And you can also see, you can go back and have a look at almost all of our 20-hour challenge.
Yes.
So exciting times on Patreon.
Yeah, just to remind you, all the profits from the fridge magnets will be going to a worthy cause. So if you're able to support us, that would be greatly appreciated.
Yes, you can see all the details about the donations to charity from our fridge magnate business. You can see them on our social media, and if there's any left in our online store, which I doubt there will be because we're so successful on Etsy, no, if there's any left, then please go ahead and buy them. That money will still go to a good cause. And it's a limited edition run. We made these by hand. We're never going to make them again. It was highly traumatic.
Don did get another scar.
I did, yeah. You'll find out where that is on the Patreon.
There we go. And with that,
It's goodbye from me.
Adios.
and it's goodbye from him. Goodbye.